Hi, good morning. And we are proceeding with clinical scenario number 11 from the ADC exam practice paper released by the ADC itself. A very interesting question. This question tests your infection control protocols and what methods would you follow in checking the patient, taking the risk of exposing yourself and your staff, what measures you would take if you were already exposed and treating a patient who's already having immunodeficiency in some or the other way. So, a very good question and very important question. It was already asked in some previous past exams, and good thing is that they have included this question in their own practice paper solving. So, okay, let's start. Mr. Manuel Zaldua is 35 years old. He presents complaining of a lot of pain on one of my left upper teeth and the gums feel swollen around the tooth. Lot of pain, okay. He was unable to sleep last night because of pain. So it's like a severe pain and you have to do something about it. Like it's probably a very acute infection and you have to see why that is happening, and because he's in too much pain you have to do something about it. He has a medical history of HIV and latent pulmonary tuberculosis. Latent, this is the key word in this entire question. Latent means he had, now he no longer has. That is very important because that would decide your level of precaution that you're going to take while examining the patient. He shows you a pathology test result of a positive tuberculin test, skin test. He is under an active course of daily rifampicin, an antimicrobial prescribed by his medical doctor. He has been taking rifampicin daily for 2 months and is required to continue taking it for another 2 months. He does not have other symptoms. Why this line is important? Because apart from TB, he is also having a history of HIV. And if he's not having any other symptom, means what? That his viral load is very well under control. If it wasn't, then he would be suffering from any other secondary opportunistic infections. So currently he is on latent pulmonary tuberculosis. He has a history of HIV, but he does not have any other symptoms and feels generally well. Very, very important keyword again. Other than his toothache. So overall his body composition is well, in spite of the fact that he's having HIV and latent pulmonary TB. Only the tooth is giving him a problem. Why this is important means that he's currently no longer having any other systemic problems apart from the tooth infection. And he's also a recent migrant from Philippines to Australia. Now you recommend to your dental assistant that you will proceed examining Manuel with standard precautions. Standard precautions are those precautions which you follow in general for every patient with or without any history of TB. She seems nervous about it because she knows the medical history and the TB. When you check your practice immunization record, you know that all staff in your practice are immunized against tuberculosis. So you find that everybody has taken a TB vaccine. This patient is on latent tuberculosis. If he was inactive, then you would have had to take precautions of airborne transmission, or probably you could have just referred the patient to an emergency hospital setting to avoid the airborne contamination. But he's having latent tuberculosis and he's also taking antibiotics, and 2 months have already gone for that. Now, what is the most important factor in deciding to proceed with standard precaution? Like why you still chose standard precaution and not some airborne precautions or other advanced methods of precautions? Because, and you're just examining him. Examination is not involving any invasiveness which would cause any blood release from the gums or the tooth. So, the most important factor when you're just examining a patient with latent tuberculosis is his latent pulmonary tuberculosis history. If that was an active one, then you wouldn't have gone with the standard precautions. Other factors are not important. So the only history of his latent tuberculosis makes you go to take standard precautions only. On examination, you note a swelling in the upper left buccal sulcus. Tooth 24 is a retained root that requires extraction. Now, this is a very important question because I saw a lot of debate going on this question over the Facebook group, and I gave exactly the same answer which is given by ADC. So I'm glad that they and I think alike on this question. What additional information is required to assess whether he needs standard or surgical aseptic non-touch techniques for the extraction procedure? See, so far you have just done a clinical examination. Now forget this patient is having TB or HIV. Just forget it. I know there is a medical history, but just forget. Imagine he is a normal patient. Now if any normal patient comes to you with just a root piece, what is the first thing that you would do? You'll take an IOPA. Why are you taking an IOPA? To see what else is happening inside. Is the root straight? Is it dilacerated? Is it having hypercementosis? Like basically you need to get an idea whether it's going to be a simple extraction or you have to surgically go and do something and remove that root. You understand? The medical history has got nothing to do with whether you would remove the tooth in a simple way or in a surgical way. That is purely basis on the root. But still, so many candidates answered this question as the decision-making procedure for them to remove it surgically or in a normal way is to find out his HIV viral load. How is that going to help you? Say his viral load comes normal. Then that would decide you to go in a normal way. What about the anatomy of the root? This is a very nice way of tricking you. So don't get tricked, don't get trapped, keep your concepts clear. The only decision to go surgical or non-surgical would be made by the anatomy of the root and root itself. Other factors have got absolutely nothing to do with it. So finding out his HIV viral load is not going to help you. Ask whether his doctor prescribed any antimicrobials for his tooth infection. Again, how is that gonna make you decide whether you're gonna go for surgery or not? Examine his submandibular lymph nodes. Why? Palpate his upper left buccal sulcus. I mean, you can do that to get an understanding of the anatomy, but what else? Take a periapical radiograph of the retained root. Yes, this is the answer. So many candidates chose option number A, and I was like, why? Why are you getting HIV in between the anatomy of the root? You understand? So this is how you answer this question. Sometimes they will give you 3-4 medical conditions and that has got nothing to do with the actual sub question that they are going to ask. That is where the trickiness of the ADC exam comes in. Do not fall in the trap. Keep it very straight and simple. Understood? Assume that you had an infection with hepatitis C virus for which you undertook treatment 2 years ago. 2 years ago. 12 months after the treatment, your hepatitis C RNA test was negative. Great. What is your responsibility prior to extracting manual's tooth? So 2 years before you had hepatitis C. Last year, the RNA test was negative. So you were exposed. So if you were actively exposed, you had some positivity, you're going to do some invasive treatment, then you will have to see if your own doctor allows you to getting exposed or your own doctor is comfortable you performing the procedure if you had an active hepatitis C going on. The RNA test is negative. What you're going to do? You will take just a medical clearance from your own GP whether you should perform any exposure procedure or not. Complete and record a self-assessment of the risk you pose to manual. No, you don't have to disclose your history to the patient. Keep evidence of your 12-monthly screening for hepatitis C antibody. How is that going to help you? What you need to get is a clearance from your own doctor. Keeping a document in the file that you had your 12-month screening is not helping you in any way. Call in a colleague who has not been infected with the blood-borne virus to complete the extraction. No. All you need is a clearance from your own doctor. And you do the procedure. Correct? Tooth 24 has been extracted and disposed of following the relevant Australian standards. Considering manual's risk factors, into which waste category should you dispose of the bloody gauze? Very good question. Any patient that comes to your clinic should be treated, and all the waste materials coming out should be disposed of as if all the patients have HIV. You understand? You should treat every patient as if all the patients have HIV. Take that kind of precautions in each patient. It's good that the patient disclose the medical condition. Many patients will not disclose you the medical condition. Then what? So the treatment of any bloody gauze from any patient will be the same with a patient who has disclosed the medical history or not, and that is clinical. The way you dispose of the bloody gauze for any normal patient is the same way you will dispose of for any HIV patient, for any latent pulmonary tuberculosis patient, with any immunodeficiency patient. It has to be treated the same. Hazardous is no, biohazard is like a clinical hazard waste only. General, I don't know what is general. Contaminated, it is contaminated. Like there is no other section of contaminated in the clinic. It's clinical waste, it's a general waste. General waste is those plastic and etc., like, you know, whichever is not contaminated with the patient blood and saliva. The clinical waste is where all the contaminated stuff, the saliva, the blood, etc. goes there, and that is always in a yellow bag, if you remember. Biochemical, there is no chemical in this. You advise Manuel that he needs to maintain excellent oral health and book another appointment for a comprehensive examination. When completing your routine oral mucosal screening, what lesion should prompt you to alert the medical practitioner? Which is a lesion which is most common in HIV patients? It's hairy leukoplakia, and that is a pre-malignant lesion, and that is why if you see hairy leukoplakia in the patient, it should prompt you to alert his medical practitioner to assess the risk of pre-malignancy. Lichen planus, many people have it. Geographic tongue is not pre-malignant. Fibroma, you can refer, but fibroma can happen even in non-HIV patients. Melanotic macule, you can refer, but the incidence of hairy leukoplakia is more in HIV patients than in other normal population. So hairy leukoplakia is the right answer here. I hope you have understood this. You can of course email me on adcwrittenmocktest@gmail.com. I'll mention the link in the description where I can share with you the Ultimate ADC Companion book and Comprehensive book, which has like more than 1,400 questions prepared from the ADC resources, helping you to solve the ADC exam. So I hope you have a nice day. See you tomorrow with another question. Bye bye.